When there isn't sufficient bone, we first do a sinus augmentation and then place the implant. These cases are often referred to as soft bone or weak bone, and several selection criteria must be considered. Today, I will present a study on an implant system specifically designed for soft bone and immediate implant placement. We observed and gathered the clinical outcomes of cases treated with the TS4 implant. Hello, I'm Professor Lee Jung-suk from Yonsei University College of Dentistry. Through the journal inside, I'd like to introduce a paper that can support clinicians in their clinical practice. Today's paper reports 18-month observational outcomes of tapered TS4 implants. This study focused on implant stability, quantified by RFA values. Let's take a closer look at the results. This is a cohort study. In other words, we follow a group of patients with shared characteristics. A cohort may consist of a single group or multiple groups. When there are multiple cohorts, comparative analyses can yield more informative results. However, this study was designed as a single cohort study. When reading clinical studies, we also consider the level of evidence. When clinical results are consistent across studies, we can pull them together in a systematic review, and that's when we say the evidence level is high. To reach there, we need a lot of clinical data. What I'm sharing today may be regarded as having a relatively lower evidence level, yet it still provides valuable clinical insights. When we place implants, we can determine how often failures occur and analyze the subsequent complications. This study reports clinical outcomes of TS4 implants placed after sinus augmentation. When comparing the more widely used TS3 with TS4, there are some clear differences. TS4 features a more tapered, wedge-shaped design. The internal body of TS4 gets narrower toward the apex. In addition, it has larger threads and larger pitch. Thanks to the large threads, as the implant goes in, the threads gain more primary stability. For TS4, an under-drilling strategy is typically recommended. In the basic protocol, if we plan to place a 5 mm implant, we drill to 4.5 mm and then insert the implant. The body is shaped for a reduced size hole, and these deep threads provide strong implant stability. Accordingly, this implant was designed specifically for soft bone conditions and immediate implant placement. In very weak bone, if you perform under-drilling for implant placement and aim for a tighter fit, TS3 may perform better, depending on the clinician's preference. So we decided to observe the stability of TS4 implants placed in soft bone after lateral maxillary sinus augmentation over 18 months. Altogether, we observed 55 implants in 24 patients. The paper explains the clinical workflow. The observation period was defined as 18 months following implant placement. According to the protocol, they performed a sinus augmentation, waited 6 months, and then placed the implants. We performed the prosthetic restoration 6 months after implant placement. Implant stability was assessed using RFA, that is ISQ, immediately after placement, at 2 weeks, monthly from 1 to 6 months, and again at 18 months. After prosthetic restoration, we conducted a 1-year follow-up. In total, 24 patients were included, and the male-to-female ratio was equal. Regarding site distribution, 41 implants were placed in molar sites and 14 implants in premolar sites. Ideally, in a controlled study, all cases would have been treated using a one-stage approach. However, in practice, some sites had very soft bone and did not achieve sufficient primary stability. In those cases, we placed the implant and kept it submerged. We had 21 cases like that. In the remaining 34 cases, we adopted a one-stage approach. So we connected a healing abutment and measured RFA values. 5 types of grafting materials were used. We used xenografts, and those derived from bovine sources were used in 15 sites. Porcine-derived xenografts were used in 2 cases. The remaining cases used synthetic bone graft. Among these 10 cases, 5 cases used BMP. In this study, we evaluated the implant survival rate, that is, the proportion of implants remaining in function. We also assessed the success rate, defined as an optimal clinical condition with almost no marginal bone loss. We evaluated that as well. In addition, we measured peri-implant bone stability. As mentioned earlier, implant stability was measured monthly from the time of surgery, and after prosthetic delivery, it was assessed again at the 1-year mark. In total, we followed the cases for 18 months. In terms of outcomes, the implant survival rate was 100%, while the success rate was 95.56%. 2 implants exhibited approximately 2 millimeters of marginal bone loss. Because our success criterion allowed up to 1 millimeter of bone loss during the first year, these cases were not counted as successes, which is why the success rate is 95.56%. On average, marginal bone loss was approximately 0.2 millimeters, indicating a very low and stable outcome. When implant stability was measured using Ostel, the initial ISQ after placement averaged 68.4. Breaking it down, one-stage group averaged 72.24, and submerged group averaged 62.19. Focusing on the key points, we examined how RFA has changed after TS4 implant placement in soft bone, combining both one-stage and two-stage cases. As expected in soft bone, primary stability was relatively low, with initial ISQ values in the 60s, but it climbed steadily, and by about 1 month, the numbers look consistently stable. The RFA values hovered around 70. Then, 1 year after the prosthesis was delivered, we removed the prosthesis and measured again, and the ISQ values had increased to the 80s. The transient decrease observed around 1 month is generally attributed to the period during which primary stability declines, while secondary stability increases. In our results, the stability dip does not appear at the 1-month mark. This is because in two-stage cases, we couldn't measure implant stability until we uncovered the implant and connected the healing abutment. However, the rest of the data follow the same pattern. From around the 1-month mark, RFA rises in much the same way, with both curves trending upward at a similar pace. At the time of prosthetic delivery, ISQ values were approximately 70 to 75. And by the 1-year follow-up, they had increased into the 80s, indicating implant stability. These findings also suggest that, in cases involving sinus graft procedures and soft bone, placement of a wedge-shaped implant can achieve favorable initial stability. We saw very stable results over a year after the prosthesis and 18 months from placement. That said, because this study was conducted in a small sample, the findings cannot be generalized to all cases. That's true for most clinical studies. Although the sample size was small, the results were encouraging. I hope they are helpful in your day-to-day cases involving a sinus elevation in soft bone. That concludes today's Journal Inside presentation. Thank you.